Everyone, and welcome to this episode of Ask the Insider. We're coming to you live from the American College of Allergy, Asthma, and Immunology in sunny downtown Anaheim, California. I'm your host, Gary Falcetano, otherwise known as the Insider today. We're going to be talking about wheat allergy, actually, and gluten-related disorders. So that's our Ask the Insider for today. As I said, I'm Gary. I'm a PA. I've been licensed for over 25 years. I have extensive experience in emergency medicine and primary care. The last 11 years in allergy and immunology, and I'm currently the scientific affair manager for allergy at Thermo Fisher Scientific. So in this role, I provide education to specialist and primary care providers, as well as work with leading researchers in the field of allergy. And one of those researchers and clinicians is actually my guest today, and we'll meet her in just a moment. We want to encourage your questions. So if you would please put your questions in the comments, and our team behind the scenes will take a look at those questions and feed them to us at as we begin to wrap up today's program. So, as I mentioned, I'm joined by a very special guest today, Dr. Anya Nowak, who's a brilliant physician and researcher. She's professor of medicine at New York University, our Grossman School of Medicine. She's also the director of Pediatric Allergy and Immunology at the Hassenfeld Children's Hospital in New York. Dr. Nowak, I'm really excited to have you here today. And if you wouldn't mind, maybe tell us a little bit more about yourself and how you got involved in pediatric allergy and food allergy.
Well, thanks, Gary, for having me. It's really a pleasure. I am a pediatrician first and pediatric allergist, so mostly seeing children with food allergies throughout my whole career. I just think like it's such an important part of medicine and growing number of children as well as adults with food allergies. And 23 years ago when I finished my fellowship, it was really very poorly understood area of allergy, so I felt like it was fascinating.
23 years ago, you were a child prodigy for sure.
Yeah.
Well, thank you so much for joining us today. Our topic is it's a pretty broad topic, right? It's, gluten-related disorders and wheat allergy. And I think we'll spend a majority of our time on wheat allergy, but I think it's important for our listeners and our viewers to understand this whole spectrum of adverse reactions that are probably related to, suspected to be related to wheat. So maybe can you start out kind of discussing the different types of adverse reactions?
So there are many, and wheat is a special grain because it has relatively high protein content. So this makes it a sort of a potent antigen that stimulates the immune system. So I'm sure you've heard about celiac disease. There's some people who cannot eat wheat or any gluten-containing grains like barley and rye because their immune system is sort of predisposed to react to a protein fraction in gluten, particularly gliadin. And these people have also propensity to autoimmune diseases. So they have a genetic predisposition. You can do genetic testing to look at certain HLA subtypes. Mm-hmm. And the diagnosis is established through endoscopy and biopsy. So if you're having symptoms, you can manifest that at any point in your life. Like as an infant, you'll have poor growth, stunting, malabsorption. As an adult, you will be having abdominal pain, anemia,
And as you mentioned, that's not an allergy, right? But it's actually an autoimmune disease.
It's an autoimmune disease, but the symptoms are triggered by the ingestion of wheat.
Which makes it seem like an allergy, right?
And the more wheat you eat, the more complications you will get in long term. So like more tendency to develop malignancy of the gastrointestinal tract, but technically it is not.
So something we absolutely need to take seriously. And I think you mentioned it, but there's kind of a diagnostic process starting with serology, going to potentially genotyping, and then small bowel biopsy. Is that correct?
This is correct. And obviously, there has to be a clinical suspicion, so manifestations, or you have like a close family member who has diagnosis and you're showing some symptoms or unexplained symptoms. In children, so in adults, you generally need to have an endoscopy and biopsy, which shows the atrophy of the villi. So that's why malabsorption. In children, if the symptoms are convincing and the serology and genetic markers are there, you could make a diagnosis without the endoscopy and
potentially avoiding that.
Yeah.
And I think that's really become more prevalent in Europe, and I think we're starting to see that transfer over to States.
I mean, it's important to make a correct diagnosis because avoidance of wheat and gluten is very difficult. Like imagine what you had for breakfast or what you're going to have for dinner. And then, some people are incredibly sensitive. So even like trace amount will trigger serious gastrointestinal symptoms.
And that's unlike people who have maybe mild symptoms when they ingest gluten, but don't have celiac and don't have a wheat allergy, right? They call that a non-gluten wheat sensitivity.
Yes.
Yeah. Can you maybe talk a little bit about that? Because it's a real thing, but we don't have diagnostic testing for it.
We don't have diagnostic testing, and there's quite a lot of controversy in the medical world about this, and certainly there's no genetic predisposition, but patients report symptoms when they eat gluten. So we take it seriously as well. Although we want to make sure that we don't overdiagnose, because gluten-free diet is a bit tricky because you cut out a lot of foods that have fiber in it. And fiber is really important for the gut.
Exactly. Gluten-free doesn't mean healthy necessarily, right?
Yeah. No, that's correct. Yeah.
So that's the autoimmune side, the celiac side. That's also the non-gluten wheat sensitivity. But then there's also allergy, true IgE, and IgE being the immunoglobulin responsible for type 1 reactions or allergic reactions. Talk to us a little bit about wheat allergy itself.
Right, so this is my disease, celiac and non-celiac gluten sensitivity, mostly an area of gastroenterology. But for the allergy, this is an adverse reaction that is IgE or a non-IgE mediated without the addition of the autoimmune symptoms. But it can be directed against gluten, but also there are other proteins in wheat that can trigger that reaction. So different fractions are associated with different manifestations of wheat allergy. And in the extreme cases, even contamination with wheat might cause very serious anaphylactic reactions. And wheat allergy is one of the most common allergies in children and in adults. So it's among the top 9 allergens that are declared.
Gotcha. So what we call now the big 9.
The big 9, yeah. Right. The big 9 with sesame.
Yeah, exactly, with the addition of sesame. So with wheat allergy in particular, again, there's a whole spectrum of reactions, right? From mild reactions to hives to full, as you said, severe systemic or anaphylactic reactions. But it's a difficult diagnosis because of wheat's relationship to grasses. Is that correct?
Yeah, so in general, that's what we grapple with, how accurate our diagnosis is, and there's a lot of cross-reactivity with the grasses. It's a domesticated grass, sure, right, like others. So people who are allergic to pollen, particularly to grass pollen, may have falsely positive test results. So a lot of the time we have to rely on the oral food challenge testing to really distinguish who is truly allergic and who just tests positive. But the symptoms, in infants can be mild or severe. And it's very interesting that wheat is such a strong allergen in adults. Like the studies from Europe are saying that, if you are having adults with anaphylaxis or exercise-induced anaphylaxis, unexplained urticaria, think wheat allergy.
And I think that's not something we've really thought of, right? Generally, we think of it as a childhood disease, and somewhere a majority of children will grow out of their wheat allergy. Is that correct?
Yes. So most of them will. Some of them don't, as always. But in general, yes. And then the big question is, can we see it starting de novo, like a new onset in adulthood?
In adults, and I think we've seen that with some recent studies with adult onset food allergies.
Absolutely.
Right? So we mentioned it's a difficult diagnosis. There's some additional diagnostics that have come into the commercial laboratories that help with that. Maybe can you speak to those?
Well, so we start from the history because that's what guides our selection of testing. Always. We do skin testing, and then serologic testing, and traditionally we had access to whole allergen tests, like a whole food, and now we have ability to test for particular components or individual proteins.
Yes.
And then people, depending on the profile, of the proteins that they recognize, they may have different presentations. So we know that there's this protein called omega-5 gliadin that is really very prominent in people with anaphylaxis or people with wheat-dependent exercise-induced anaphylaxis, which is like a very specific form.
So let's unpack that a little bit first. So with kind of what we think of as a typical allergy, we ingest the food, we have symptoms usually fairly rapidly after, and the triane-19, which is the omega-5 gliadin, is associated with that as well, especially in children, right? Being more specific. But then you mentioned there's this other syndrome, wheat-dependent exercise-induced anaphylaxis. So let's talk about that a little bit more.
Yeah, so I also mentioned it in the context of adults, because it's more common as you get older. So, we don't really see it that much in children, but once, like in teenagers, young adults. So those are people who can eat wheat when they are sort of sedentary, inactive, but when they eat wheat and then they go jogging, running, playing basketball, they all of a sudden have pretty severe symptoms, like allergic symptoms, hives, wheezing, shortness of breath, like true anaphylactic reactions. And it is really something that can be a diagnostic conundrum because
the delay, right?
Yeah, because of the delay, and they've used to eat that food, for their entire life, and nothing has changed really, that they can recall that might trigger that. It just happens, and then we can really unpack it by using the component testing.
Because this triane-19 is more highly correlated with it. Understood. Now,
because there are also other foods that, so that's what we should really explain, that there could be other foods that cause food-dependent exercise-induced anaphylaxis.
Not all wheat-dependent.
Not all wheat.
It's food-dependent as well.
Like sometimes people react to milk, or they may react to celery or shellfish. So that's why, having this test for wheat is very helpful.
So, I think something that's poorly understood by non-allergists, patients and non-allergist clinicians, is this idea of cofactors and how they can come into play. So not just, as you mentioned, with wheat, but some other foods even, there are other triggers that can potentially cause someone to have a reaction when, if they didn't have those triggers, they could eat the food. Yeah. So what are some of those triggers?
So generally those are factors that either increase reactivity of the immune system. So for instance, when you have a virus and you have a fever, your immune system goes on high alert, is making all kinds of cytokines, and it's easier for it to mount that allergic reaction. And then there are factors that decrease the integrity of the intestinal barrier. So if you drink alcohol, or if you take non-steroidal anti-inflammatory drugs like aspirin or ibuprofen, that's what happens. Your gut is getting more leaky, like in very lay terms, right? So you start absorbing the food before it's fully digested, and the less digested food, so the bigger chunks of protein are more allergenic, so they have more ability to trigger the immune system. So, if you have a little bit of the allergy, sensitivity, at rest you're fine, but then once you sort of are presented with that, partially digested protein, then you start reacting.
Exactly.
And then also the other factors are when you take drugs that lower your ability to digest. So if you take, antacids, PPIs, right. So then it's certainly, there are studies that show that this plays a big role.
Allergy isn't as straightforward as it seems.
No, it's not. And also, as we talk about it, sleep deprivation and menstrual period in women. So hormonal changes and like the biological clock.
Which is exactly why, the first thing you mentioned was a detailed history, and that history includes potential cofactors as well.
We all, as a food allergist, we spend most of the visit really asking questions, and I want to know what you ate, how much you ate, when did you eat, what did you do after you ate it, when did the symptoms start. Before that guides me, it really serves as a base for my decision.
So we mentioned this wheat-dependent or food-dependent. There's also another kind of little bit rare disorder or syndrome called Baker's allergy or Baker's asthma. Maybe discuss that a little bit for our foodies in the audience.
So whenever you're heavily exposed, like in an occupational setting, to a food, you could break through your tolerance, right? So you develop tolerance to the food as a child, like soon after it's introduced into the diet. And it's called the oral tolerance. It's a very, very powerful mechanism. But it turns out that if you're heavily exposed, not through eating, but through contact with the skin or through inhalation, like in bakers, right? The flour is in the air, they inhale it. You could, as an adult, start having symptoms, and it usually starts from asthma, right? Like it starts from asthma symptoms, from inhaling, but then it can progress to more systemic reactions.
Very good. So, how is that diagnosed? Obviously, history. I mean, we always start there, right?
It's the history, absolutely.
Yeah.
And then, I don't remember exactly which components are relevant for that.
Yeah, so I think we've seen correlations with tri-14,
right?
The
lipid transfer protein,
right.
yeah. So that would be helpful. But it's for that situation, the history will be very important.
Exactly. That's where diagnostic testing is really more confirmatory. Yeah. So I think we've done a pretty good job of kind of breaking out the different wheat disorders. We could probably spend hours, right? But other than avoidance, because for eons, the only treatment for allergy has been avoid what we're allergic to, or if, in the case of environmental allergens, try to reduce our exposure. Maybe some antihistamines and epinephrine for a severe reaction. But what about treatments that can help to resolve allergy? What's going on in that area?
So there's actually a lot of investigation going on in different ways of addressing it, because we certainly can do immunotherapy. So that's our thing, as allergists. We desensitize, and then you could potentially cure somebody. And we know that it's easier to accomplish in younger children than in adults, but it's possible to, by feeding you very small amounts of the food that you're allergic to, gradually increase your tolerance to it. So we call it a threshold, the amount that you will react to. So we may not fully cure you, but we could say, from reacting to a bite, you could, then eat a much larger amount and be safe and have no symptoms.
And at the very least, not worry so much about those accidental exposures, right?
Right. And there's so much more going on with the biologic treatments, which are not allergen specific. So for instance, there are studies with the anti-IgE molecules, not only for wheat, but for other foods that.
And these are molecules that actually block IgE, which causes allergic response.
Exactly. Right? Or, there are molecules like small molecule drugs that are sort of blocking the allergic cascade, the reaction that is triggered.
Any other future kind of, I know there's a lot of studies, so nothing is really FDA cleared or in the mainstream yet for wheat allergy.
And it's probably not going to be for a while, unfortunately. I think that depending, on the age of the patient, and their desire, how much they want to eat the food, you will choose either, oral immunotherapy that I discussed, or, potentially sublingual immunotherapy, which has been tried for milk and for peanuts. So there's really no reason why it wouldn't work for wheat, but it hasn't been tried.
Gotcha. And some people are doing it kind of off-label.
Off-label,
but hopefully we'll get something more. Now, one other thing before we close, and that's, and I think it's so important because we've seen that most primary care providers, at least in the recent future, were not encouraging their infants, whether they be pediatric practices or family medicine practices, to have early introduction of foods. And can you maybe talk about what we've learned with, and I know that's a whole topic on its own, but what we've learned with early introduction and how important it is to help prevent allergy?
So that's a great point, and thank you for bringing it up. So we've learned that for foods, for sure, for peanut, very likely for egg, and also probably for other foods, that the earlier you introduce it, when the infant is ready. So I'm not talking about introducing foods when they're 2 months, or generally after 4 months, when they have this developmental readiness for for chewing, swallowing. Then we should be introducing foods. And the reason why we should be introducing is that, as I mentioned before, oral tolerance is very powerful. So if you introduce something through ingestion, very few people develop allergy, right? Like most of us don't have allergies,
exactly.
and that's how we tolerize. But if you have a skin condition, so in infants this is eczema, right? Like itchy, dry skin, rash, they can come in contact with the food through the skin. So we know there's food in the environment, in their bed, in the living room, and it's food residue on the hands. And it turns out that there's this dual exposure hypothesis that if you are exposed to food through skin, you're much more likely to become allergic than when you're exposed through eating. So it's sort of trying to beat the clock. Then you make them eat before they
get exposed
through the skin, or before they get exposed enough to trigger.
Because we know that there's a lot of food allergens that are just in our environment. We don't think about that.
And
that can actually come. They found peanut allergen in like most houses, even in houses where they're avoiding peanut, right? So I think that's a great place to close that part of the discussion. I wanted to see if we have any additional questions. So we don't. I want to thank you so much for spending some time with us, and
My pleasure.
This was a really enlightening discussion. Gluten disorders, wheat allergy is not the easiest diagnosis. I think we've established that. Finding a clinician, especially a specialist that is familiar with food allergy and can help work through the diagnosis, I think is most important. I want to thank everyone out there for tuning in. Remember, food allergies are becoming increasingly prevalent, but you can be prepared with resources, tips, easy to digest information on Allergy Insider. Dr. Nowak, thank you so much for joining us. Did you have any closing remarks?
Well, thank you for having me. I think it's important that we raise awareness of how accurate diagnosis is important, and avoidance of overdiagnosis, as well as early introduction of foods to prevent, because we definitely want to prevent rather than treat.
Thank you again for joining us. Stay tuned for our next episode of Allergy Insider. If you don't already, follow us on Instagram, like our page on Facebook for all things allergies. We really are your medically backed resource. Thanks again. We'll see you next time.
So you do